Good morning. It is my honor and pleasure to be with you today. We have a great program for you today. To all those in our audience and those online, we'll be talking about the management and diagnosis of CTEPH. This is a underdiagnosed condition, but one where we can cure the pulmonary hypertension for these patients. It is an extremely rewarding group of patients to take care of. They come in very sick. Often they've been misdiagnosed for a long time, and we have the potential to cure their disease. I have with me today a panel of world experts on this condition. And to get us started, first I'd like to introduce Dr. Juan Umania, who is one of our upcoming chief residents, who will start with a case presentation.
Good morning. We have a case presentation of a 36-year-old male who had a prior history of GERD and epilepsy, and then started having progressive shortness of breath 6 months prior to admission here at the hospital. And workup showed extensive PE. He was started on anticoagulation and oxygen and was transferred to a center for management. So we see the CTP here, which you're going to see that there's a lot of clot burden in the main pulmonary arteries, interlobar and lobar arteries, and some subsegmental occlusions. It's a significant disease, a dilated PA. And then here you start seeing all of the clot burden in the main pulmonary arteries. Tracks down into the interlobars and lobars and subsegmental occlusions. Mostly lower lobe disease, some middle lobe on the right and upper lobe on the left. So then we see the VQ scan here. This is the anterior posterior view. You have the ventilation on your left and the perfusion on the right, and you see that it's mostly a predominantly lower lobe disease with some middle lobe involvement and upper lobe on the left. So then the echo, we saw that there was good left ventricular function with a severely dilated RV and moderate dysfunction and 3+ TR. You can see here the images. In the right heart catheterization, the right atrium pressure was 10 with a pulmonary artery of 87/40 with a mean of 54 with an index of 2.39 and a calculated total pulmonary resistance of 12.08. And so we decided to go forward with a bilateral pulmonary thromboembolic and a tricuspid valve repair. Here's a picture of the specimen that was gotten out in the OR. And then you can see that the post-operative VQ scan, there's a significant improvement of the perfusion on both lower lobes and middle lobe on the right and upper on the left. So, and then post-operative echocardiogram, also the RV recovered. It's now mildly dilated with mild dysfunction and trace TR. And post-operative hemodynamics are significantly better with a right atrial pressure of 4, pulmonary artery pressures of 28/8, and a mean of 16 with an index of 3.2, and now a calculated total pulmonary resistance of 2.6. He was discharged home on post-operative day 6 and on room air and doing pretty good.
Good morning, everybody. I thought I'd give you a quick historical perspective of how we got where we are, and then my colleagues will take you into the modern era. So this is an old slide deck, as you can see. It's dated November 2005. I want to give you a perspective of where this field started, and then the team here will give you where we are. And as a introduction and an interest in the history of cardiothoracic surgery, I put this slide in. If it wasn't for a pulmonary embolus, we might not be doing the 5,000 to 6,000 cases we do every day, and our perfusionists are here. It was John Gibbons who was at the Mass General and watched a young woman die from a massive pulmonary embolus and began to think through how one could take the blood, oxygenate it, remove the carbon dioxide, and then bring it back. And maybe if we had something like that, we could have saved this young patient's life. So he began to do a lot of this work in his garage. And you can see the first screen oxygenator, and these things were massive. They were, the size of a couple refrigerators. They took tens and tens and tens of units of blood to prime, quite complex. And the work was all started in the 30s and came to fruition in the 50s. And think about that, 20 years of struggling to get this from the thought to the bedside. So that's all because of a pulmonary embolism. I think the team here will show you about the surgery. So when I started to do it, I took over from Dr. Cosgrove in the mid 90s. We were doing these endarterectomies. I don't think we had a full understanding exactly how to do it and how to get into the right plane. The anatomic approach was quite simple, but the physiologic management of these patients with perfusion and how we managed them in the intensive care unit was critical, and I don't think we were particularly good at it at the time. Here's just a figure of mobilization of the cava. I used a cold fibrillatory approach. I didn't typically arrest the heart. Others have in San Diego have arrested the heart. But one of the key things that really changed what we did is that in 91, Pat O'Daly out of San Diego published in the Annals the instruments they used. And it sounds, kind of silly, but the instruments, at least in my mind, were critical. And they had these suction dissectors that they had developed. And they had a small opening that allowed you to suck the blood that would always return during the operation, and also use it as a dissector that when you were in the plane and doing the endarterectomies. So our team here took these prototypes and actually developed these suction dissectors. I don't know if you guys are still using them, but this was developed from the San Diego group in the 90s, and then I just stole their concept or borrowed it, and we used it. But this was really critical to our ability to do endarterectomies deep in the pulmonary artery. So that was critical. So this article was 93. The outcomes were challenging. Reperfusion injury, 10%, delirium and mental status dysfunction, 11%, mortality, nearly 10%. And a lot of it was related to how we perfused the patient. And then with Gus's help, I think we really started to understand the reperfusion injury and the hyperperfusion management of the patient in the postoperative period. We learned a lot from the guys in San Diego, Jameson, and then Madani, who took over. They focused on their last 500 in this article in 2003. And our goal at this time was to drive towards their results, really trying to get better. They broke it down into a couple of different categories. You guys still use this type? So this is all out of San Diego, where it is, and then the results of how well patients did depended on how easy it was. So central clot and scar, you could extract at a relatively low risk, and as you got the more diffuse, it was a higher mortality. Now, during this time, I felt like I was sort of the Lone Ranger doing these operations, and what I really needed was a partner on the medical side, because so much of the outcome was dependent upon the preoperative evaluation. A lot of these patients had COPD. They had other medical disorders that led to pulmonary hypertension. And you can imagine if somebody's sick and they have X disorder and they're sitting around, they get pulmonary emboli. But what is really the main cause? So understanding VQ scans, perfusion abnormalities, which wasn't in my sort of sweet spot, was came along. Gus came along, and I think when Dr. Haracy came and really helped on the medical side, we developed this partnership. He helped me in the intensive care unit. We fought regularly about anticoagulation postoperatively, whether to give heparin or not. But through that relationship, we started to get a better understanding, and we got better at the preoperative management. We had the instruments for intraoperative management, and then postoperative management. Also at that time, Torrey McGrath came. He was a cardiac anesthesiologist that trained in San Diego. And he brought the anesthetic management, the steroids, the various things that they were given that I didn't know in detail about. And we started to use the San Diego intraoperative management for lung protection and brain protection that we needed to reduce that delirium and the reperfusion injury. So around the late 2000s, we really had the right team in place. We had cardiac anesthesia, we had the perfusion technology. I had developed a deeper understanding of how to find the right surgical plane. We had the right instruments, and we had the medical team. A little bit later, I don't know, where is Ehab? I thought he was, oh, there you are, over there. I saw you over there. The last, I think, step in our developing the multidisciplinary team was really having a dedicated imaging specialist and interventionalist that could begin to help us understand where the scar was, and then begin with some of the balloon angioplasty for the really distal lesions. And so over the course of about 20 years, we were able to bring this team together. And as I think my colleagues will show you, the results are absolutely phenomenal. And the extent of scar that they're tackling now is at that type 4 that was really challenging for us to manage 20 years ago. So it's been a great pleasure to work with everybody here, and it's been fascinating and fantastic results.
Thank you, Mike. Good morning. And I should acknowledge, all credit goes to Nick. I think we wouldn't be here without your pioneer work and your leadership. And yes, we had a lot of fights. I think I lost most of those. But we're going to talk about CTEPH pathophysiology now. So yeah, we do think that CTEPH starts with one or more episodes of acute pulmonary embolism that fail to resolve, right? But the mechanisms that mediate this transition from acute clot to chronic clot are really not well understood. They probably involve things like impaired fibrinolysis, impaired angiogenesis, which are critical for clot recanalization, and also an enhanced inflammatory milieu at the level of the pulmonary vasculature. How frequent is CTEPH after PE? The best data out there, I show you there, it's about 3% of survivors of PE. And this study also gave us a couple of important risk factors from the clinical perspective. Recurrent PE and unprovoked PE are things that should enhance our suspicion for the development of CTEPH after a PE. However, when you look at these epidemiologic studies and also in clinical practice, you need to be mindful that unfortunately, the recognition of CTEPH lesions that you can see there to your right is frequently not done. So people are not trained in teasing out what chronic clot looks like, and it's not uncommonly mischaracterized as acute PE. So patients presented with clot in the pulmonary vasculature and right ventricular strain are labeled as acute PE with RV strain, but they may be CTEPH all alone, and so requires a special expertise to pick those up. And in fact, several studies have documented this. I'm showing you the very last one, where out of a group of 300 patients, during follow-up over 2 years, 5 of them developed CTEPH. But when the authors went back and looked at the index CT scan, 4 out of those 5 had already CTEPH lesions on the index CT scan. So I think this is an interesting phenotype of this disease that presents acutely in our PERT team, and in the CTEPH team, we frequently see these cases. And obviously you can imagine that the management would be quite different if you already know that CTEPH is present there. Of course, we all have seen acute PE evolve to chronic PE, and I show you an example there where to your right, classic retraction and stenosis after an acute PE. Our group actually has shown that that type of acute PE that you see there, completely occlusive disease, is associated with a greater than 3-fold increased odds of CTEPH development after an acute PE. So again, sort of simple imaging phenotype that should enhance your suspicion of CTEPH development after an acute PE. Now, CTEPH may represent the tip of the iceberg. We do know that there is a larger number of patients out there with cardiopulmonary limitations after an acute PE. Some of those patients have the classic CTEPH lesions on imaging, but don't have pulmonary hypertension at rest, at least. We call those CTED, or more recently, chronic thromboembolic pulmonary vascular disease without pulmonary hypertension. And those patients, after careful phenotyping with invasive cardiopulmonary exercise testing, frequently benefit from our interventional and even sometimes medical therapies. Which brings me to why people with CTEPH are limited. And they're limited or functionally impaired by two reasons. The first one is increased dead space fraction. And in this slide, I show you data even compared with patients with pulmonary arterial hypertension. So the dead space fraction of CTEPH patients is way beyond what you observe in patients with pulmonary arterial hypertension. And of course, the reason is this massive ventilation perfusion mismatch that these patients have. The second reason, of course, is right ventricular failure, and this is due to increased right ventricular afterload due to the disease at the level of the pulmonary vasculature. But here comes another key pathophysiologic concept in CTEPH. So when you look at imaging studies, and this is data from nuclear medicine, comparing acute PE in orange versus CTEPH in yellow, you see that for any level of pulmonary vascular occlusion, the pulmonary resistance in CTEPH is much higher than what you would anticipate compared to acute PE. And the only reason this is possible is because all these patients with CTEPH, in addition to the proximal occlusive thrombofibrotic process, they also have microscopic vasculopathy. And when you look at the microscopic vasculopathy under the microscope, it looks exactly the same as that we observe in our patients with group 1 pulmonary arterial hypertension, or what we used to call primary pulmonary hypertension. This microscopic vasculopathy is key to understanding what happens with these patients. This is likely the reason why some of them don't respond well and they're left with residual pulmonary hypertension. Some of this is likely the reason why some of these patients bleed in the operating or in the ICU after endarterectomy. And of course, the operation works, as you will see later. So this microscopic vasculopathy regresses, but the degree and how fast it regresses can be quite variable. And I think that we still don't understand some of these phenotypes, and that's part of the research that we're trying to do here. So again, dual compartment disease. CTEPH is featured by both large vessel obstruction, but microscopic vasculopathy. And this occurs both in areas distal to open arteries, and this is due to overflow-induced vasculopathy, basically what you see in patients with left to right shunt, where they have all this cardiac output going through the pulmonary vasculature over a long period of time that leads to vasculopathy. There may be some growth factors also produced by the ischemic lung that some data has shown contribute to this as well. And vasculopathy distal to occluded areas, this is likely due to lung ischemia, low shear stress that has been demonstrated that leads to endothelial dysfunction, and systemic collaterals. Of course, the body reacts by trying to bypass these obstructions and perfuse the distal pulmonary arteries. And this is something that actually the two of these slides are courtesy of Nick. The video there is really cool, this collateral coming out of the right coronary artery perfusing the right lung. And the other picture is, our surgeons see these collaterals in the lungs, in the chest wall. And on imaging to your left, we see it also. And this is really another important concept, because this is the reason why you will hear patients require circulatory arrest during the operation. And so this is my last slide. So just to sort of remind you that CTEPH is a condition that affects the length of the pulmonary vasculature. And this is why we have different treatment modalities to address the large vessel thrombofibrotic process and medical therapy to address the microscopic vasculopathy. And frequently, we think about these patients as requiring one or more of these therapies. Thank you for your attention.
Thank you, everyone, for the opportunity to speak with you this morning. So I'm briefly going to discuss medical therapy in CTEPH. So these are the most recent 2022 European Respiratory Society guidelines for CTEPH management. And there's really two major things to discuss with regards to medical therapy and treatment of this disease. So I'm going to briefly discuss therapeutic lifelong anticoagulation. And then in select patient populations, there is some benefit from pulmonary vasodilators. And we'll talk a little bit about how we select those patients and what we use. So lifelong anticoagulation is a class 1 recommendation for these patients. They're vulnerable to recurrent thromboembolic events. It's recommended that they remain on full dose anticoagulation. The most commonly used are vitamin K antagonists or direct acting oral anticoagulants. There's actually no prospective randomized controlled trials comparing these two classes of medications for patients with CTEPH. So a lot of what we know about the safety and efficacy of them are extrapolated from observational registry and retrospective studies. So when you actually take a little bit of a deeper dive into the literature, thinking about this topic, it's pretty well established that vitamin K antagonists, which we have the longest runway with, are safe and efficacious for preventing recurrent thrombotic events, as well as have a favorable safety profile. When you look at the literature about what's described with CTEPH patients and DOACs, it's actually a little bit more controversial. So there have been several large registry studies that have been published that demonstrate that patients who are on DOACs may have slightly higher rates of recurrent thromboembolic events compared to those on vitamin K agonists. However, outcomes are very similar between those two patient populations. They have similar surgical outcomes, similar hemodynamic improvement after pulmonary endarterectomy, similar survival, and similar rates of bleeding. I will mention that Coumadin is recommended in patients, Coumadin or one of the vitamin K antagonists are recommended in patients with antiphospholipid antibody syndrome. So our general practice is that if somebody's been on a DOAC, hasn't had a recurrent PE, and is stable on it, we typically keep them on it unless there's a strong indication to switch. So I want to talk now about several patient populations that benefit from pulmonary vasodilators. In my mind, there's basically three different types of patients that will end up on these medications. So the first patient population are patients who end up with residual pulmonary hypertension after they go for pulmonary endarterectomy. And I'm going to describe that phenotype a little bit on the next slide. The other two patient populations are people that are essentially non-operable. So you can be technically operable, but have medical contraindications to pursuing pulmonary endarterectomy, which honestly, there are very few absolute contraindications to considering surgery for this disease. Advanced cirrhosis with portal hypertension is an absolute contraindication. Advanced parenchymal lung disease, where you would be able to reach the thrombotic burden, but you'd only be reperfusing diseased lung is a relative contraindication. Or anything else that would make somebody intolerant of cardiopulmonary bypass with circulatory arrest. The third patient population are patients that when we review them in a multidisciplinary CTEPH conference, we deem them to be not operable. And essentially, that's a largely subjective decision. There's actually no hemodynamic cutoff that we would say, this patient has too much pulmonary hypertension to safely get them through surgery. But it's all about weighing the risk of the relative ratio of thrombotic burden to hemodynamic insult. Essentially, the less thrombotic burden there is with higher and higher pulmonary vascular resistance, the more we believe that somebody has a significant amount of microscopic vasculopathy and that you're not going to get the significant immediate improvement that you see when there's an extensive amount of thrombotic disease. So those patients, under those circumstances, get recommended to have medical therapy plus or minus some mechanical treatment with balloon angioplasty, which we'll talk about later. So just to kind of define what residual pulmonary hypertension is a little bit more, we actually have very nice data looking into this. So this is a study that was published in 2016, essentially where this group out of the UK looked at 800 patients that underwent pulmonary endarterectomy and did right heart catheterizations 3 to 6 months after they had their surgery. And they found that patients who had residual pulmonary hypertension with an inflection point of a mean pulmonary pressure of greater than 38 or a PVR of greater than 5 really had worse survival long term. So generally, our practice is that if somebody has a PVR greater than 4 at 3 to 6 months after surgery on their heart catheterization, or if they have a PVR between 3 and 4 and they still have symptomatic pulmonary hypertension, we tend to start vasodilators under that set of circumstances to try to treat any microvascular component of the disease that's going on. So this is a very busy slide, and I'm not going to go through it line by line, but essentially it's listing all of the clinical trials of pulmonary vasodilators that have been undertaken. So essentially, I'll just kind of mention that every family of pulmonary vasodilator that we currently have FDA approved for pulmonary arterial hypertension has been tested in some form for CTEPH. To highlight a few, Riociguat is currently our only FDA-approved medication for treating CTEPH in the United States. I'll go through some details of that trial in the next slide. Macitentan, which is an endothelin receptor antagonist, has been tested in several trials. Both of them, or the MERA trial, for instance, met its primary endpoint. It improved pulmonary vascular resistance, improved exercise capacity and biomarkers, but didn't meet its patient-centered clinical endpoints. It didn't get FDA approval. And then recently we were running another trial looking at different doses of macitentan in this patient population, and it was stopped early, not for safety, but for futility. They just weren't seeing a huge clinical benefit. I'll mention that subcutaneous treprostinil demonstrated benefit for patients in terms of improving hemodynamics, functional class, and biomarkers, and is FDA approved to treat CTEPH in Europe. And selexipag, which is a prostacyclin receptor agonist, is approved for treatment of CTEPH in Japan. So just to highlight our sort of most important clinical trial here in the United States. So CHEST-1 is the trial looking at riociguat versus placebo for patients with CTEPH. It was completed about 10 years ago. The patients included in this particular study were people who either had non-operable CTEPH or residual pulmonary hypertension after pulmonary endarterectomy. And it was about 75% non-operable, 25% residual. They've noted that patients had improved exercise capacity as well as improved hemodynamics, biomarkers, functional class, and there was a trend towards improvement in time to clinical worsening. So this is currently FDA approved for treatment for our patients where it's indicated in the United States. So in conclusion, lifelong full-dose anticoagulation is indicated for all patients with CTEPH. Pulmonary vasodilators are appropriate for either non-operable CTEPH or patients with residual pulmonary hypertension after endarterectomy. Typically, the first line is riociguat. Under certain circumstances, we will add in either additional or other pulmonary vasodilators, as there is, hemodynamic evidence that they're helpful, although they're off-label, so currently not approved here in the United States.
Thank you for the opportunity to come and speak. I'll be talking about imaging and endovascular interventions. The three imaging modalities we're going to focus on are VQ scan and SPECT VQ scans, CT scans, particularly dual energy CT and angiography. VQ scan is typically the first study that you're going to run into, especially when screening these patients. It's not sensitive, it's not specific for CTEPH, but it's very sensitive. So you have a patient that comes in and gets a VQ scan that's normal, you've essentially excluded the diagnosis. And this is what you typically try to see for these kinds of patients. So you have the ventilation images and you have the perfusion images, and here you see there's globally decreased perfusion to the left lung compared to the ventilation. On the right lung, there's multiple mismatched defects. It doesn't tell you that this patient has CTEPH, but this is somebody that's going to require further workup. We typically try to incorporate SPECT CT images. This adds another layer of anatomical resolution to the scan. We can kind of see exactly the extent of the disease, which segments are involved. And additionally, it's a lower quality CT scan, so you do get a look at the lung parenchyma, which can be important, certainly in patients who have a suboptimal ventilation scan. CT scans, everybody's familiar with CT scans. Dual energy CT does have the added benefit. You're actually obtaining two CT scans on the patient using two different energies, and the iodine is going to absorb those energies differently. So there's different vendors on the market. You can have literally two source and two detectors, or one source that just oscillates back and forth between the two images. And the iodine is going to absorb the energy differently from one scan for the other, and based on the absorption difference, you can actually get an iodine map. And iodine goes where there's blood vessels, so this can act as a surrogate for the perfusion. Pulmonary angiography, we don't routinely do that in every single patient, but it is another modality that allows us to look at the vascular anatomy in real time, look at the perfusion in real time, understand where the defects are, and we typically use it to adjudicate where perhaps the VQ scan and the CT scans are not quite so clear-cut as to which the treatment strategy should you undertake. We've incorporated cone beam CT into our practice. So again, just like with SPECT, it's a two-dimensional picture. When you look at an angiogram, the cone beam CT gives you a three-dimensional picture. So you really get a much more profound understanding of the vascular anatomy in three-dimension. Plus, it has much more improved contrast resolution. And case in point here, We're going to focus on this anterior basal segment here. So this is what a traditional CT scan here, fairly proximal here on the anterior basal segment. Is there really disease? It's a little hard to say for sure. This is the angiogram of that patient looking at the anterior basal segment. Again, it looks okay. And at first glance, we're not seeing any proximal disease. The vast majority of disease really here seems to be distal, maybe small vascular disease. This is somebody perhaps that really medical therapy. Again, we're just talking about just this branch. But if we take a step back and take a look at how we can assess this disease using cone beam CT, this is a cone beam CT of that same patient at that same exact spot. And you can actually clearly see a much more proximal web that's completely invisible on the CT scan. In hindsight, you maybe can go back and see it, but those webs are much, much easier to see. And if you look, the contrast resolution here is much, much improved with cone beam CT compared to traditional contrast CT. So again, looking at that patient, so now we do have more proximal disease, but also if you look at the distal vasculature, because of the improved contrast resolution, actually the distal vasculature is intact. So this is actually a much more proximal disease, and this is easily accessible to a surgeon. And that has dramatic implications for the treatment planning. This is just another different patient, just to see the difference in contrast resolution. This is a different anterior basal segment. Again, these are all the different branches. And you can see here the level of detail, because you're injecting directly into the pulmonary artery, the vascular detail here is much, much improved with the cone beam CT. From an endovascular intervention, it's impossible to tell what the optimal obliquity is for every single segment, every single branch, and every single patient. The vascular anatomy is much too complex, and you can't really just do an angiogram in every single obliquity. Well, with a cone beam CT, you can actually get all the obliquities at the same time, and in real time in the angio suite, decide which is the best obliquity that you're going to use. So we're actually doing this with a sterile mouse on the table. These are the three branches that we're looking at the upper lobe. Well, in order for us to really open up and see all those branches not superimposed, we need a really steep ROA oblique. That's not a typical obliquity that we're going to choose. And we can actually predict what the angiogram is going to look like. This is the data from the cone beam CT, and this is what the angiogram looks like. So I don't need to go back and do every single angiogram and every single obliquity. I find the obliquity that I need, and I put that C-arm in that obliquity and plan out the anatomy. I know the trajectory that I need to take, so as long as I stay in that trajectory, I'm not going to cause a pulmonary artery perforation, so it adds an extra layer of safety to this procedure. It also allows us to see things that we may have otherwise missed. Again, this is a patient that we're doing an endovascular intervention on the posterior basal segment of the left lung. At first glance, there's a branch here that's diseased. On the CT scan, you're looking, okay, there's disease here. It's a little hard to delineate that anatomy. But if you look at the cone beam CT, you see all the other branches, and it's actually two branches that are diseased. It's impossible to see that there's two different branches here that are affected just based on the angiography. When we do the reconstruction, we can identify the origin of that vessel. It's distal to this side branch. Then when you get in, do a super selective injection, now we can find the origin of that vessel. Now, this would have been impossible to see based on the non-selective diagnostic angiogram and the traditional cone beam CT, CT. Now that we know where the vessel is, we can actually really escalate the level of aggressiveness for how much force we can apply without really perforating or ending up somewhere bad that could potentially cause some harm to the patient. So once we cross, we prove to ourselves that we are where we need to be. And indeed, there's actually a very nice dormant vessel which was globally hypoperfused. We do the angioplasty, and now instead of just opening one vessel, we double the amount of vascular territory that we recruited. So putting this all together, we have the SPECT CT scan. We map out the anatomy. We figure out every single segment that we need to take a look at, subsegment that we need to take a look at. We correlate the cone beam CT with, okay, this is a segment that's here, this is a segment that's here, and then basically try to formulate a treatment plan based on that. Do the angiogram, do the angioplasty based on that data, tackle every single perfusion defect that you can, and the goal is to go from an angiogram that looks like this to an angiogram that looks like this. And from a SPECT VQ scan that looks like this to a SPECT VQ scan that looks like this, there's obviously significant improvement in all the hemodynamic parameters as well as the patient's symptoms. Patient selection, like our colleagues alluded to, surgically inaccessible disease, patients who are high surgical candidates, or patients who are unwilling to undergo surgery, or patients who develop a recurrent residual disease after surgery. I just want to show here, we've done a lot of improvements in the catheter-directed therapy for the acute PE, but we're not quite there for the chronic PE. So even in patients who are not surgical candidates or decline surgery, this is not stuff that you can balloon out of existence. It's just too bulky to really treat. Disease proximal that's in a surgically not a good candidate patient could potentially be ballooned if it's around this size, but this really requires surgery. Thank you for your time.
All right, thanks, Mike. So we saved best for last. This is the exciting presentation for everyone here. So we're talking about the surgical management of the CTEPH. And these patients here, they get evaluated through our weekly CTEPH multidisciplinary team. And really the first question we'll try to answer, as you heard in a prior presentation, if these are operable or not. As pulmonary endarterectomy is really the only curative treatment modality for these patients. If not, then they're gonna go for medical therapy, plus or minus catheter intervention. Lung transplant has been really rarely done for these patients. In the last ICHLT registry data, around 1% only required lung transplant, and these mainly patients who had residual PH after actually a PE. As part of evaluation for these patients, they undergo multi-modality testing, which include echocardiogram, look at RV function, RVSP. If they have a history of DVT or PE, some patients will have VQ scan, CT, PE, as Dr. Haddadine has shown us. Some patients also will have cardiopulmonary exercise testing. Obviously, the key or a critical the testing for us is right heart cath numbers, and pulmonary angiogram for some select patient that we really want to delineate the anatomy before our intervention. So I want to touch base quick about CTED versus CTEPH. So CTED is chronic thromboembolic disease, and these patients don't have pulmonary hypertension at rest. It's only with exercise. And for these patients, again, we need to exclude some other etiologies for the shortness of breath or symptoms they have, such as lung disease, if they have left-sided cardiac pathology, or body habitus or decondition. And these patients still can get offered pulmonary endarterectomy surgery. These are a list of condition or disorder that may mimic CTEPH, and here where come really of value the multidisciplinary evaluation for these patients, because these patients won't benefit, or these condition won't benefit from pulmonary endarterectomy. So evaluation through our specialist team can rule out and identify these patients who won't benefit from pulmonary endarterectomy. So when you look on operability and we assess the risk for the patient, we look at proximal versus distal disease. So simply using the University of California, San Diego group classification, we have a proximal disease for level 1, which starts in the mean PA. Level 2 starts at the lobar branching. Distal disease will be level 3, which is a segmental level, and level 4 is subsegmental disease. This slide shows the spectrum of patient we have. So on the left side, this will be the low risk, a combination of proximal disease, PVR less than 10 with normal RV or mild dysfunction. So these we know will have a smooth surgery, and we can have good prediction of their long-term outcomes as well. On the other side of the slide, the other spectrum of patients, when they have distal disease, they have high PVR and RV dysfunction is moderate to severe. So we need to be careful about these patients because they may have a rocky course, or the long-term outcomes may be less predictable than the spectrum on the left. But not all patients fall in these two spectrums. There is a mix of these factors together. So you may have a proximal disease, but high PVR or RV dysfunction. These patients still can be offered surgery and do well. Or the other way around, like they have distal disease, but not super high PVR or normal RV. So we still can take them to surgery to do a distal extraction. We ideally we want at least 3 months of anticoagulation before surgery that help resolution of the acute component and maturation of the chronic plane for us to do our dissection and during the surgery. Some patients also who have really high PVR, they may start medical therapy to reduce their PVR a little bit and smooth their preoperative course. On the other hand, some patients may present to us with acute severe presentation. They're in ICU and high flow oxygen with RV dysfunction. We really cannot get them out of the ICU. These sometimes we take them to the operating room and do pulmonary endarterectomy. As you see in this picture, the patient came to us from an outside hospital in a different state. He has a subacute component proximally, but also on top of chronic disease distally, as you see there. He did well with the pulmonary endarterectomy surgery. The approach for the pulmonary endarterectomy surgery include median sternotomy. We do it on cardiopulmonary bypass with deep hypothermic circulatory arrest. We cool down to 18 degrees for 30 minutes. We start with the left side endarterectomy. We aim to limit the circle arrest time to less than 20 minutes and then reperfuse in between and then do the right side. This is the setup or how to expose for both PA, and we see this similar slide from Dr. Smuldera's presentation. So on the right PA, we expose by retracting the ascending aorta to the left side of the patient, the SVC to the right side, and then we expose the right PA through that. For the left PA, we use a heart net to elevate the heart and push it to the right side of the patient to expose the left PA all the way down to the hilum. And the key here, this is a very critical step, is how to identify the plane, and this something comes with experience. So ideally, a low-risk patient will have proximal disease, and you really need to get on the right plane. So if you go too deep, that may cause catastrophic bleeding after surgery. If you go too shallow, you won't be able to follow the disease to distal segmental and subsegmental level, as you see in the picture on the left side. So on the right side, we try to identify this, get with a blunt suction in the right plane, and then we can follow it distally to all these branches. And these are example of patient who came to us with subacute and top of chronic disease, but we take the subacute component first and then identify the proximal plane at the lobar level and follow these all the way down to segmental and subsegmental levels. Some of the early complication after surgery is early pulmonary dysfunction. Some of these patients may still require some oxygen in the first few days after surgery, and that could be due reperfusion injury or steal phenomena, meaning some areas of the lung that were occluded before now getting more blood flow from other areas that was receiving normal blood flow. Other complication could be pulmonary hemorrhage. As we see, if you go deep in the plane, that may cause catastrophic bleeding. These were treated with bronchial blockers. They may need IR embolization of the bleeding vessel. Sometimes they need ECMO support as well. For patients who had some component of microvascular disease or inadequate or incomplete extraction, they may end up with residual pulmonary hypertension and RV dysfunction, and they will have rocky course after surgery with inotro, pulmonary vasodilator, plus or minus ECMO support as well. So in regard to outcomes, pulmonary endarterectomy surgery provides survival benefits. So as you see here in this report from the International CTEPH Registry back in 2016, people who underwent pulmonary endarterectomy surgery had survival of 90% at 3 years versus medical therapy were 70% in 3 years. From this study from the UK, they show the longest follow-up up to 10 years survival was 72%. On the graph on the right side, it's interesting. So when they split the cohort into the first 500 patient and the second 500 patient, they found significant difference in survival benefit from the surgery at midterm, which just highlight the importance of experience and learning curve for the surgery as well. This has been shown in other reports from International CTEPH Registry that best outcomes was found in volume, high volume center, which is defined by doing more than 50 cases a year. And that can be due to that the surgeon be able to extract distal disease and drop the PVR down. We looked recently in our outcomes, and this study will be presented at this year ICHLT. From 2008 to 2022, we've done more than 300 patients. The operative mortality was around 2%, which just dropped actually last couple of years to 1%. Survival at 5 years was 91%, and survival at 10 years was 73%, which is comparable to what has been reported in the literature. So these are main takeaway points. So CTEPH still underdiagnosed. Pulmonary endarterectomy surgery is only available curative treatment for these patients. The key for successful surgery is actually multidisciplinary team evaluation at the specialized or high volume centers to identify the best candidate for the surgery. The surgery itself is tedious and require meticulous dissection to get on the right plane for complete surgical extraction of a distal disease, and definitely there is a learning curve for surgeon as has been shown in the literature. And I think we have time to run a quick video about a patient with CTED that has mainly lower lobe and middle lobe disease or lingual lower lobe disease. So we start with the left side, we did our circle rest. We start proximally identifying the plane that we're gonna follow down all the way for distal branches. We're starting with the lingular branches first. And really meticulously try to push and using the blunt dissector to get far to the segmental and subsegmental levels. Now going, finishing the lingular branch, and then we'll start going to the lower lobe branches. Then we switch to the right side. We reperfuse in between, and we do our circle rest for the right side. Again, similarly, we get in the proximal plane first and follow that distally. We start with the middle lobe branches first, and then we're going to go down to the lower lobe branches. Patient did well. This is an extraction specimen and of the CTEPH patient. She did very well and went home and no oxygen. Thanks.
So we have some time for questions, if I may start. So, Haitham, you talked about a learning curve, and I definitely felt the learning curve when I started learning this operation. And we get asked a lot by other surgeons who are interested in developing a CTEPH program at their center. Can you talk a little bit about your learning curve? How many cases it took you to feel comfortable doing these operations, and the volume of cases, and the keys to being able to build a successful
Sure, it's
program?
an important point. I think it's only available centers with resources, that high volume center, and you have expertise from other surgeons too. So I think we scrubbed together maybe up to 10 cases first, seeing you how to do it, and then you helped me up to maybe 10 or 15 other cases until I've become more comfortable doing it on my own. So I think for success of this learning curve for the surgeon, it really need to be done at center of high volume, and it requires all the expertise, because you still may need support at the beginning when you start off these cases.
And Dr. Haresi, so you talked about how 3% of patients with PEs may develop CTEPH. So that is estimated to be about 5,000 new cases of CTEPH in the United States every year. Yet only about 500 or so cases of CTEPH are performed annually in the United States. So what's the discrepancy? How do we rectify this situation?
Yeah, no, that's a great point. I think that underscores the fact that CTEPH remains vastly underdiagnosed, right? So there are a lot of people out there who are persistently dyspneic or functionally limited after having an acute PE or a DVT even. And frequently their symptoms are ascribed to comorbidities, obesity, smoking, or something else, but people don't think about this condition, right? So that's why I always say, in anybody with dyspnea and a history of PE or DVT, and quite frankly, even if you have dyspnea, you don't know why, get a VQ scan. If that's normal, then you're good to go. You don't have this disease. But if it's abnormal, proceed with further evaluation. So I think that's a really key point. There may be some overestimation, as I mentioned. Some of those estimates of 3% may include some CTEPH that presented as acute PE. That may be part of the problem, but it's certainly the case that CTEPH is under-recognized, and we need to do a better job at finding those folks, because we can help them significantly.
Gus, I have a question for the residents and fellows, and you'll be managing patients in the intensive care unit. I think part of our learning curve, my learning curve, was how you think of pulmonary hypertension in the immediate postoperative period, and that and the hyperperfusion that I think we went through in the early postoperative period. So if a resident or fellow gets called and the nurse or whoever it is says the pulmonary pressures are 70 or 80, and what are you going to do about it? When you hear that, how do you assess the patient, and what are you thinking to determine whether you do anything or not?
Yeah, so I think it depends on a couple of things. First of all, and this is another point related to the earlier points, so there's no level of
pre-op pulmonary hypertension that would make surgery a bad idea, right? So some of the patients who have the highest pulmonary pressures receive the greatest benefit from the operation. So if the patient started with a mean pulmonary pressure of 60, and in the post-op period, the mean pulmonary pressure is 30, the systolic is 60, 70s, but they're doing well, they extubate well, they come off inotropes and pressors, we don't worry about it. However, if the patient is struggling, they're not coming off of the ventilator, we're not able to wean off the inhaled vasodilator, that's when you start thinking, all right, maybe we need to intervene earlier than later. So it really depends on how high the pulmonary pressure is starting, and I think that's a key point now, because I think there's some phenotypes that we're still struggling to understand. We have one patient in the hospital right now that we struggle a lot. We decided to go for surgery, and amazing results, right? And he had systemic pressures, and now he's got normal pressures. And the amount of clot wasn't really that striking, at least initially, on the imaging studies, right? So yeah, this is an interesting disease. But I think we think about the clinical course of the patient. If they're flying post-op, we wouldn't get too concerned. If they're struggling, then we have some tools that we can help with.
Any questions from the audience? So Dr. Goyanis, if I'm...
Kind of
yes.
Unrelated, but since you're all here, between Dr. Adedine and Dr. Spadero, what's the role of surgery in acute PE nowadays?
Between 7 a.m. and 7 p.m.
I agree. The acute PE space, we've gotten pretty good. I mean, I used to get jealous of Mike's pictures, when the catheters were used to come out, the little tiny, chicken feed pellets that we used to extract, and he'd send out these massive clots. But with the larger bore aspiration catheters, we can actually do a fairly significant extraction. You do have to be careful, patient that has a clot in transit across a PFO. That, I think, to me, is an absolute reason to go to the operating room. Somebody who has the acute large component, but there's a significant chronic component. Those are really high-risk cases to try to go in there, and sometimes you're stuck having to go in there and do something. So those are, in my mind, I think that the biggest reasons where surgery still plays a role. Your garden variety acute PE, you can still go in there and do a fairly reasonable, successful extraction, but those are two key demographics. And those usually present between 7 p.m. and 7 a.m.
All right, Dr. Goyanis. Yes, Mary.
Sorry, I missed the beginning for Alice and Gustavo. Is there an ideal PVR you want to drive them down to with medical therapy before we enter the operating room? Like, do you want to say, hey, I'd love to get them PVR below 5 if I can? Because I know we've had patients who've been on IV or just sildenafil. So what do you guys usually do?
Yeah, that's a great question. I think for me, it's not so much an actual PVR value as how much the right ventricle has responded to medical therapy. So we've had several patients that start out with double-digit pulmonary vascular resistance, and we bridge them with medical therapy. Their right ventricle improves to the point that we think that they're going to have a little bit more reserve to get through surgery. I like to see it come down out of the double digits, but that's not a contraindication to proceeding if there's a significant thrombotic burden.
I think it also just depends on how accessible the disease is. If, for example, the patient today that I'm going to be operating on has a PVR of 12, a very accessible disease, probably level 2 disease, so I'm fairly confident we can get a good result. But 2 years ago, we had a young patient under age of 20 who had COVID and then developed CTEPH, had a PVR of almost 20 with level 4 disease. So that was a patient where if I were to go in and we can't get anything out, or we're only able to get a little bit out, that patient may not survive. So we decided to medically manage that patient and got the PVR down from 20 to about 10 or so. And then that gave us a little bit more safety. We were then able to go in. Luckily, we were able to get quite a bit of disease out, and her PVR did come down to about 4. So the last question I'd like to ask is we're seeing more and more patients with CTED. So they've had a history of PEs, but they don't quite have very high pulmonary hypertension. Some of them are symptomatic. Some of them are just mildly symptomatic. Can you talk a little bit about your approach to these patients, how you think about these patients? What are some of the tests that you like to see before we entertain either balloon angioplasty or surgery?
We're seeing a lot of those cases now, and I think that the key there is you need to put together the clot burden with symptoms. We need to be certain that the symptoms are due to the clot, because these are big operations, big procedures, and so we only do that based on invasive cardiopulmonary exercise testing. So we put the catheter, put a spirometer, we measure oxygen consumption, carbon dioxide production, we see them up, they pedal, and we measure the pulmonary pressures and the oxygen consumption and carbon dioxide production and the gas exchange with an arterial line with ABGs. We put all of that together, and if we see exercise-induced pulmonary hypertension with poor right ventricular response, and or if we see dead space ventilation, right, or what we call ventilatory inefficiency, then we feel confident that if we reperfuse those lungs, patients are going to feel better. So that's the only circumstance where we would recommend either angioplasty or endarterectomy. And a lot of patients, you'll see that they don't have any of those, and we leave them alone. And we actually have a cohort of patients that we follow over time with anticoagulation alone, and most of them actually don't progress. If they don't have those abnormalities when we meet them, majority of patients actually stay stable over a couple of years. But it's pretty satisfying too, because if we show those physiologic abnormalities and they go for surgery or BPA, most of those patients come back feeling much better as well.
All right, terrific. I sometimes call those operations performance-enhancing operations. I had a patient whose only complaint was when she goes to Orange Theory, she can't run as fast as she used to, and now she's able to run faster.
Yeah, this happens in highly trained people, not uncommonly, actually. Yeah, so they run their marathons and their.
Yeah. Hey, Gus, one last question. I think we got to go. Yeah, I read somewhere that 20% of PEs are I don't know, I have the number right, are related to pacemakers and catheters. So is that number correct? Is that a common, and will it cause chronic hypertension?
So I don't know about 20%, but certainly endarterectomy centers, including us, are seeing more CTEPH patients with chronic indwelling catheters, right, pacemakers and others. And the phenotype of that disease tends to be a bit trickier, right? They tend to be distal, they tend to be smaller clots, they tend to be distal and more difficult to extract. Correct me if I'm wrong, but I think that we're seeing more and more of that. And it's a tricky patient population. I don't know if it's 20, certainly it's not 20% of our cohort.
Yeah, I don't know if I have the right number.
But it is increasing.
It caught my attention that it was, significant.
Yes.
Yeah, I've got two patients I've done, one with pacemaker and one with dialysis access. And yeah, the disease were distal, there is no proximal plane, and some of them had calcified disease too in the distal branch.
Right.
So it's a little bit trickier to get out.
Right.
Great. So I'd like to thank you all for attending, and to those online. The key message here is if you have a patient that has unexplained shortness of breath or residual shortness of breath after a PE, think CTEPH, get a VQ scan. VQ scans are not done very often. These diseases are not found by accident, unlike aortic aneurysms, for example. So you really have to go and look for them. And feel free to call any one of us. We're happy to take a look at these patients and do everything we can to help them. So thank you very much on behalf of my co-panelists. Have a great day.